So I'll start this long day of transplant by introducing some basic concepts of immunobiology that really explain a lot of what we do in the clinic. So, as you know already, what we do in transplant is mainly based on a little of evidence and mainly based on what we know of the biology, a lot of experience, and in some cases a lot of ego. So this is Sushruta. This is the father of surgery. This is the first surgeon we know about who performed transplantation. He did autografted skin, and this is tissue transplanted in the same individual. So in this case, the immune system does not recognize this tissue as foreign and do not attack. This is the same case of the isograft. This is where the tissue is transplanted between individuals of the same species that are genetically identical. This is the case of in a human, those are the identical twins. So this is the case of the first kidney transplant that happened in the Brigham in 1954. In this case, no need for immunosuppression. This Italian surgeon successfully tried autografted skin, but he failed consistently with allografted skin. This is where tissue are transplanted between individuals of the same species, but are genetically non-identical. In a human, this is all cases of transplantation except the identical twins. And he gave the first hint of the immune rejection. But not until Peter Medauer, who's a Lebanese British scientist, that described the immune reaction in 1951, and he's the first to suggest that giving immunosuppressant can allow allotransplantation. Xenografts is the tissue transplanted from one species to another. This is, a few years ago was a joke in the transplant field. Nobody believed that this is going to happen because of the redundancy of the barriers that the human immune system can recognize on a xenograft and can reject. But no more. So the introduction of the CRISPR-Cas9 technology by Harvard scientists revived this modality. And I won't be surprised that in this next time you're recertifying, we're going to have a talk on xeno or even a day on xeno because we're all going to be dealing with xenografted patients. So the beginning is always with the stem cell in the bone marrow differentiating into two big arms of the immune system. Those are the adaptive immunity and the innate immunity. The adaptive immunity, those are the T and the B cells. Those are the cells that have receptors on their surface that can recognize specific antigens and react to those antigens, and only to specific antigens. And this is different from innate immunity that are non-specific, and usually they are driven into the area of inflammation by chemokines secreted by the adaptive immunity and activated by cytokines. So those are the mercenaries of the immune rejection. So the T cells are called T cells because they are generated in the bone marrow, but they mature in the thymus. So T for thymus. And this is by acquiring this T cell receptor here. Every few T cells have one T cell receptor that recognize only one antigen. And this is called a clone of T cells. And we're born with over 1 billion of T cell clones. Each clone recognizes one antigen, and the billion cover most of the possible antigens. Why this is important? So when we get an infection, not that all our T cells go after this infection, only few clones that recognize specific antigen on this bacteria or virus get activated. This is the same case in the transplant. Only few T cell clones are activated by the allograft. But what we do currently in transplantation is we suppress the whole billion T cell clone. This is our patient do not do well. This is our patient develop infections and malignancy. And this is why I always say that this field is still in its infancy until we develop antigen-specific therapies. And this is what my lab is working on. So billion of T cell clone, including clone that recognize our own antigens. So why we don't all develop autoimmunity? Because in the thymus, those T cell clones are exposed to our own antigen before they are released to the periphery. And the one that recognize our own antigen can get eliminated. So our immune system basically is not that it differentiates self from non-self. our immune system do not recognize self. But this is not a perfect system, so a lot of autoreactive T cells escape to the periphery. So why we all have autoreactive T cells, so why we don't all develop autoimmunity? There is a subtype of T cells in each clone, and that express this master regulator, the FOXP3, which make those regulatory cells, when they encounter an antigen, they don't attack the antigen, but in fact they attack the cells attacking the antigens, attack the T cells, so those are suppressive cells. And I'm talking about those because you're going to see those coming in clinical trials soon. So when we talk about rejection, there is multiple steps. First, T cells need to recognize the alloantigens. The T cell need to be activated, and then the T cell activate the rest of the immune system. But we're also going to talk a little about how the immune system is regulated at the end, and this is important in what we do in the clinic. So step one is recognition of the antigen. So for T cell to recognize an antigen, this antigen need to be presented by structure to the T cells. And those are the MHC molecules. So those are the HLA molecules that are present on all our tissue. Their role is to present antigen to the T cell. So, but in the case of transplantation, which is a man-made situation, so the T cells are in fact able to recognize directly the donor HLA antigen as a foreign molecule and attack it. So we have two classes. So the MHC complex is this cluster of genes that is present on chromosome 6 and produce those MHC molecules. We have two classes of MHC molecules, class 1 that's present on all nucleated cells, class 2 that's present only on antigen-presenting cells, and class 1 is A, B, C, D, R, D, P, D, Q. And there is a lot of polymorphism to the point that, in this room, there's no way that two people that are not siblings will have the same HLA antigen on the surface. Why is that? So the HLA molecule function is just to present antigen to the T cell. So why we all don't have one HLA molecule? Why we need all these variation in the HLA molecule? So imagine we all have one HLA molecule X, and a pathogen learned to mutate over thousands of years. This will wipe out the whole human race. However, if we have two HLA molecule X and Y, people who have Y HLA molecule and XY will survive. And all these, the polymorphism in the HLA molecule is not to make the life of transplant nephrologists hard, but it's mainly to protect us from the pathogen mutations. So this is chromosome 6. We have two alleles, one from mom, one from dad, but those genes are codominantly expressed, which means that the A from the mother is expressed and the A from the father is expressed. So in fact, we don't have 6 antigen, but we have 12 HLA antigen on the surface of our cells. So why we talk about 6 antigen match and 6 antigen mismatch in kidney transplant? Well, because in the early era of transplantation, A, B, and D are thought to be the most immunogenic, and people concentrated on those. Now we know that this is not true, that all of them are important, all of them are immunogenic, if not in acute rejection, in chronic rejection. So this explains why if you have a 0 antigen mismatched kidney coming from the disease list, this is not a perfect kidney. So this is not a perfect match. The chance that they are, this kidney is matching on the C, DQ, and DP is almost impossible. This explains why for 0 antigen mismatch coming from the disease list, we still give induction therapy and we still give maintenance therapy. This is different if you get a 0 antigen mismatch from a sibling. So the chance, if you're matching on the AB and the DR, the chance to match on the rest is almost 100% because you're inheriting the whole haplotype. So when you get a 0 antigen, this explains why we don't give induction therapy in most centers for 0 antigen match or 2 haplotype match living related kidneys, but still we give maintenance immunosuppressant. Why is that? So if they are matching on all the HLA molecule. And the reason is the minor antigens. So the minor antigens are, those are proteins that have normal function in the cells that can differ by 1 or 2 amino acids between individuals without affecting their function, and only identical twins will have the whole sequence of the protein the same. So what happens is the proteasome will degrade those proteins and present them on the surface of the allograft, and the T cells of the recipients are able to recognize those small differences in the protein as non-self and attack. And this explains why even for 2 HLA match, 2 haplotype match kidneys, we still give maintenance immunosuppression, although the risk of rejection is significantly less. So first question, a 25-year-old woman with ESRD secondary to reflux nephropathy, status 0 antigen mismatch, living-related transplant from her twin brother. Which one of the following is true? So I'm not gonna give you time to answer the question, to finish on time. The trick here is to know that those are not identical twins. Those are 2 haplotype match. There is a need for maintenance therapy because of the minor antigen. There is a risk for acute or chronic rejection. The induction therapy should be with depletion therapy. That's not true. Either no induction therapy, or if some center they give non-depletional, usually IL-2 receptor blocker. This match is perfect for major and minor transplant. It's not true. So the answer is none of the above. So the rejection starts by taking the kidney out of the donor and inducing ischemia to this kidney. What happened that those injured cells start secreting stress molecule. Those are the chemokine and the cytokines. So once you put the kidney back in the recipient, those chemokines are released to attract the immune system, and the cytokine activate this immune system. Not only that, so the injured cells start expressing a lot of HLA molecule on their surface, thinking that there is a possible infection. So more ischemia, more immunogenicity, so the kidney become more immunogenic. So this explains why for deceased kidney, we have tendency to use depletional induction therapy, because the risk of acute rejection is significantly more compared to living kidneys. And this explains that why with longer ischemia time, there is a higher risk of acute rejection. So, sitting, on a deceased kidney transplant saying, oh, this is still ATN is not a good practice. And we biopsy all our patients by day 7 if they don't open up to look for acute rejection. So now the kidney is back in. So we have 2 types of antigen-presenting cells. Those are professional cells that present antigen to the immune system. We have the donor, so there are antigen-presenting cells coming with the organ. Those are the donor antigen-presenting cells. And we have the recipient antigen-presenting cells that come to the organ, harvest cells, basically pick up those HLA antigen and start presenting them on the surface. And they go into the secondary lymphoid organ. Those are the lymph node, those are the spleen, where they present the antigen to the T cell. So in the case of the donor antigen presenting cells, so the donor cells have a intact HLA molecule on its surface. And this is important because this HLA molecule is recognized directly by the T cell, by multiple T cell clone. Why is that? Because this is a complex protein that's formed by multiple peptides. And then they can stimulate more than one T cell clone. This is different from the recipient antigen presenting cells that will take this HLA molecule, degrade it, and only present pieces of it on the surface. So there is significantly less clone of T cell are stimulated by the indirect recognition by the recipient antigen presenting cell. So when the donor antigen presenting cells is stimulating, this is called direct recognition. This is a very strong reaction, but this is short-lived because the donor antigen presenting cells will die very quickly. And the recipient antigen presenting cells give this indirect recognition, which is a weaker reaction, and this is, we think, is more important in chronic rejection. So why this is important? Because this explains why the risk of acute rejection, in addition to the ischemia reperfusion injury, cause the highest risk of acute rejection early on post-transplant, and this risk goes down with time. This is why we give induction therapy early on post-transplant, and we give the highest dose of maintenance therapy, and we start reducing those medications over time. So, question 2. So we have a 58 years old Caucasian female, history of ESRD due to reflux nephropathy, PD for 10 years, called in for cadaveric kidney transplant, 2 mismatches. Patient is not sensitized and negative cross-match. The cold ischemia time is 24 hours. The warm ischemia time is 45 minutes. Those are the serologies. She was induced with TIMO, started on steroid and CellSap. The surgery was uneventful. Post-op day 1, the sluggish urine output. By day 7, urine output picked up, but she's still dialysis dependent. She's on a full dose of CellSap and a very good level of FK. Which one of the following statement is correct? Thymo induction was not appropriate as she had a good matched kidney and no preformed HLA antibodies. So this is a long ischemia time of 24 hours. This kidney is very immunogenic. Giving TIMO is very appropriate because the risk of acute rejection is very high. Patient has no increased risk for rejection, and delayed rejection is simply explained by the prolonged cold ischemia time. That's not true. Biopsy is needed as soon as possible to root out acute rejection, and this is the correct answer. Prograft should be stopped as it's contributing to the delayed graft function. This is a common mistake. Prograft should stay at a high level because the patient is at high risk of rejection. So now the kidney is back in, the antigen-presenting cells went to the secondary lymphoid organ, and now time to stimulate those T-cell clone that recognize those specific antigens. So this is the T-cell receptor recognizing this antigen presenting by the HLA molecule. This is not enough to activate the T cells. And the T cells need to realize that it's interacting with the actual cell that is presenting cells to it. And so need another signal through a co-stimulatory molecule to realize that it's in close contact to a cell. So this is what we knew about co-stimulatory molecules in 1999. This is continued to grow. We know more than 300 molecules of those by now. But the prototype remained the CD28 molecule because it's one of the most important co-stimulatory molecule, and it's the one that made it to the clinic. So naive T cells express a lot of CD28 molecules. So when the cell is interacting with an antigen, the CD28 molecule binds to CD8086 and get activated. However, the activated T cells start expressing the CTLA4 molecule, and the CTLA4 molecule bind with higher affinity to CD80 and 86, so start stealing 8086 from the CD28, inhibiting this positive signal. But not only that, this is a co-inhibitory molecule. It will give negative signals and the cell crash. And why this is important? This is important to restore homeostasis after each immune reaction. So the T cell get activated here, proliferate, remove the infection, then start expressing those CTLA4 Ig to give a negative signal and for the clone to crash and go back to its normal size. So if you are in a lab and you know this biology, what do? You take the CTLA4 molecule, you fuse it to an Fc portion of a human immunoglobulin, and you make the CTLA4 Ig molecule, and one of its mutant is the belatacept, and if you give belatacept to those two cells interacting, will bind to CD86 and will inhibit this interaction. And the cells become anergic. And this is the molecule that made it to the clinic, and this is the benefit trial with Flavio Vincenti, and now you all know the good result of this trial, and Steve Gabardi will go over this in detail in a second. So to really understand all the different medication we use in transplant, you need to remember this through the T-cell activation. So this looks complex, but it's not. The way I would look at that the T-cell is interacting with the antigen. It needs a second signal from co-stimulatory molecule. Together will activate intracellular pathway. The most important to remember is the calcineurin, which is a phosphatase dephosphorylate NFAT, which allow NFAT to go into the nucleus. The NFAT sit on multiple promoter of genes, activate multiple genes. The most important is the IL-2. So the IL-2 will be produced by the T cells, bind to the IL-2 receptor on the surface of the T cell, activate a third signal. This is the PI3K mTOR pathway. And the PI3K-mTOR is a proliferation pathway, is a survival pathway that a lot of cells depend on. This is the most commonly mutated pathway in cancer that maintain those cells in continuous proliferation. And then, so the PI3K-mTOR push the cells to go into cell division, and for that you need synthesis of new nucleotide. So to remember the immunosuppressant, this is the OKT3, this is monoclonal antibody that bind to CD3, that's the TCR receptor, and deplete T cells. This is no more used, but it's going to come back to the clinic. This is the co-stimulatory blockers work here. Calcineurin inhibitors work here, which explain why those are one of the most powerful immunosuppressants we have. They are early on in the T cell activation process. IL-2 receptor blocker is your induction therapy, Simulac. It's non-depletional. It binds to the receptor and do not allow signal-free to continue. So, and by now you know that this signal, this induction therapy must be weak, because IL-2 is not the only cytokine produced and not the only cytokine that drives T cell activation. mTOR inhibitor acts here and inhibits cell proliferation. This explains also why mTOR inhibitors are our preferred agent when we have patients with cancer. This is why also those medications give you wound healing issues, because it inhibits cell proliferation. So the anti-metabolite, the CellSAP, and the Myfortic and the Imuran act on here and inhibit new nucleotide synthesis and then inhibit cell division. And this explains why those cells give you leukopenia. So, and then again, Gabardi will go over this in details. So, a 28-year-old Caucasian female, ESRD due to presumed hypertension, 4 years on dialysis, had a 4 mismatched kidney 3 years ago. Non-sensitized patient, creatinine 1.1, had no episode of rejection or infection, but she's developing recurrent squamous cell carcinoma over the last 2 years. Patient's immunosuppressive therapy are full dose of CellSAP, tacrolimus with a level of 6 and prednisone of 5. Which one of the following statement is correct? Switching tacrolimus to rapamycin associated with decreased risk of recurrence of squamous cell carcinoma in a randomized controlled trial. PI3K-mTOR pathway is highly activated in anti-cancer T cells. This pathway is activated in cancer cells, not in anti-cancer T cells, and it's indicated in those cases. Patient remains at high risk for rejection due to her young age, but tacrolimus should be switched to rapamycin. So this is a patient who 3 years post-transplant, and what we know from biology now that by now the direct recognition went away, the ischemia perfusion effect went away. Not only that, the cells are expressing the CTLA-4 on their surface, which make them more exhausted and more inhibited. So this is why with time we are able to reduce our immunosuppressant, and this patient is not at high risk of rejection 3 years post-transplant. Prednisone should be stopped to reduce the risk of cancer recurrence. This was associated with very high risk of acute rejection. Late withdrawal of prednisone is not a good practice. Tacrolimus should be switched to rapamycin. That's true, but MMF reduced to 500 within 2 weeks. This is not a good practice. This should be done over a month. She's on a very high dose of CellSAP by 3 years post-transplant and should be reduced, but not at the same time of switching to rapamycin, because rapamycin is a weaker immunosuppressant than tacrolimus and is associated with a higher risk of acute rejection. So the correct answer is switching tacrolimus to rapamycin is associated with decreased risk of recurrence and this was shown in a randomized clinical trial in the New England Journal of Medicine. So now the T cells are activated. You have the CD8 T cells become what we call cytotoxic T cells that have the machinery in them to kill the target cells. So those T cells were activated in the spleen, now goes into the peripheral blood, yeah? So they come to this new kidney and they circulate, they get to the glomeruli here and into the peritubular capillaries. So if we take a cross section, then this is what you see. Those are the tubules, and this is the peritubular capillaries where those cytotoxic T cells are circulating. And if you take so this is a representation. This is the peritubular capillary. This is the basement membrane, and those are the tubules of the cells. So the ischemic cells express a lot of those selected on its surface to slow down those cells that are coming in, and the chemokine that are secreted by those kidney attract the immune system. This is how the T cells know that they need to slow down here and go inside the tissue. And now they come in contact of the tubular cells, they recognize those as alloantigen, and they start attacking. And this is exactly what you see in the histology. So those are the small lymphocyte here are your, small nuclei are your lymphocyte, and the big nuclei are your tubular cells nuclei. So those are lymphocyte infiltrating your tubules here, and this is tubulitis, and this only can be done by cellular rejection. This is the hallmark of cellular rejection that's diagnosed on histology, and this is the same thing. And this is to show that CD8 T cells are able to kill directly the cells. So now the CD4 T cells are activated, and those are helper cells. They don't have the machinery to kill target cells, but they secrete a lot of cytokines to activate the immune system. And what they do in particular, activate your B cells. So this is in the spleen where the T helper cells go and interact with the B cell that carry on its surface an immunoglobulin that recognize the same antigen that stimulated the T cell in the beginning. So this is a very antigen-specific process. And those B cells start getting activated, proliferate in the germinal centers, differentiate into plasma cells, and this immunoglobulin they have on their surface, now they can start secreting it. And those are your antibody against the HLA antigen. And the plasma cells goes into the bone marrow, and they live for a long time. So if you have those antibodies produced, they come into your new kidney, come to the capillaries, and now physically they can bind to the HLA molecules on those endothelial cells that in the glomeruli, but also in the peritubular capillaries. And this is what happens. So they bind, they activate complements. You have this C4D that's a byproduct that will bind to your endothelium. And if you stain for the C4D, this is what you get. So this is only can be done by antibody-mediated process, where the antibodies are binding to the endothelial cell within those small capillaries, activating complements. So you see it here, and you see it in the peritubular capillaries. But this is not the only way the antibodies can can induce injury in the target cells. The antibodies can bind to the HLA molecule and cause direct injury. You don't need complement activation. The cells can swell, the cell can proliferate, and your vessels can tighten. They can activate complement, but also by binding to the antigen, you have those innate immune cells that are circulating. They don't know what to do. And then they bind through their Fc receptor to this antibody binding to the antigen. And they get activated and they start attacking. This is how they know that they should start attacking. And if you take this peritubular capillary here, and you see this neutrophil attacking the endothelium, this is antibody-mediated rejection, even if your C4D is negative. And this explains why you have C4D negative antibody-mediated rejection. And so the classic presentation that you can measure your antibody in the periphery, and you have antibodies against the donor HLA antigen, and also when you do the biopsy, you have C4D positive. But if you have C4D positive and you don't find your antibody in the serum, you still have antibody-mediated rejection, because either you're not detecting the antibody in the blood, or you have a non-HLA antibody that is driving this phenomenon. There are other antigens than the HLA. But also you can have C4D negative and still have antibody-mediated rejection. Usually you detect the donor-specific antibody in the blood. In very rare cases and very difficult cases to diagnose, both are negative. So this is a case of a pregnant woman. So the T cells of this pregnant woman recognize the HLA antigen on the fetus coming from the father as foreign. And those T cells get activated. Those specific T cell clones activate the specific B cell clone against those HLA antigen. They differentiate into plasma cell, they start producing antibodies, and now the patient has antibodies against those HLA antigen that are circulating. The son, 21 years later, decide to give a kidney to his mom. So now the mom has antibodies against his HLA antigen. They put the kidney in, the antibodies bind to those HLA on the endothelial cells, activate complement, cause microthrombi, and the kidney turn blue on the table. And this is what we call hyperacute rejection. And this was happening in the early era of transplantation. So then when they figured it out, they wanted to develop a test to predict this before it happens. So if you have a donor and a recipient, you want to know if this is a possibility before you proceed. So what you would do, if I was there, then I would probably do that. I would take a piece of the kidney, and then I put a serum from the recipient that potentially have some antibodies against this kidney, put them in the same culture, and see if those antibodies can induce injury to the kidney cells. But this is not a practical test to do. So you want a surrogate cells for those donor kidney that are easy to obtain and easy to perform an assay with. And this is why we use the donor T cells. So we use donor T cell in a cross match, not to test the immune system of the donor. We don't care about the immune system of the donor. What we care about is that T cells has HLA class 1 on its surface that's similar to the HLA class 1 that's present on the endothelium of the kidney. So now you want to simulate this situation. You put those donor lymphocyte with serum from the recipient. And if the serum of the recipient has antibodies against the HLA molecule of the T cells, you add anti-human immunoglobulin and you add complement. The complement will form this MAC complex, will perforate the cell. You add a dye, the cell turns blue. And this is a positive T cell cytotoxic cross-match. And this is the only absolute contraindication for transplant. Everything else we do in transplant is not absolute. So we got more sophisticated, and so now we don't have to do. In addition to doing the cytotoxic cross match, we can do another technology that is easier to perform and more sensitive. So what you do is still a cross match. So you take donor lymphocyte and you add the recipient serum. So if the recipient serum has antibodies against the HLA of the donor, they will bind. You will add anti-human immunoglobulin, but in this case has fluorescence on it. So which will turn the cell fluorescent, and when you run it through the flow cytometer, you know that if the fluorescence is positive, then you know that there is antibodies against the HLA of the donor. But if you have a positive flow cross match, this doesn't mean that you have this means that the antibody is binding to the HLA antigen, but doesn't mean that this antibody will activate complement. Only cytotoxic T cell cross match can tell you that. This is why before proceeding to any transplant, you need to know what your cytotoxic T cell cross match is. So you can have a positive flow cross match, but with a negative cytotoxic T cell cross match, and this is not an absolute contraindication to transplant. And it depends on the center whether they proceed or not. Depend also on the patient and how many offers they are getting. But the flow cross match is not an absolute contraindication to transplant. So now we got even more sophisticated. So we have those beads, and on those beads, each bead will have one HLA, one human HLA bound to it, and this is why we call it a single antigen bead assay. And we have beads that represent all the human HLA antigen. You put them in your, you mix them with the serum of the recipient. If the serum of the recipient has antibodies against any of those HLA antigen will bind. You use another fluorescence, and this combination of the two fluorescence coming from the bead and coming from the antibody will tell you what antibody you have in the serum. So this is the Luminex assay we do, and then shows you if you have antibodies in the serum and what kind of antibody you have. But if you have a positive HLA antibody, and it happens that the donor had the same HLA antigen, So you have a donor-specific antibody. Is this a contraindication to transplant? Well, this Luminex is only telling you that you have this antibody. It doesn't tell you if this antibody is binding to the antigen. Only flow cross-match can tell you that. And it's not telling you if this antibody activates complements and potentially can cause hyperacute rejection. This is the cytotoxic cross-match. So there are 3 layers of testing we do. We do Luminex on everyone, but having a donor-specific antibody is not a contraindication to transplant. If your flow cross-match negative and your T-cell cross-match is negative, it's safe to proceed to transplant. However, those patients are at very high risk of developing rejection. And why that? Because remember, to get to the B-cell activation and differentiation, you got a T-cell that recognized the antigen already, and the T-cell got activated before and developed memory. So all these patients have in them T-cell that's primed against the antigen. We don't have a tool to measure that. We have a tool to measure the antibodies, so the end product of that. So once you put the kidney in, you have a primed T-cell that can cause acute cellular rejection. So those patients are at increased risk of acute cellular rejection, and also at increased risk of antibody-mediated rejection, because this antibody can later, the titer of those antibody can go up, now can start binding, and also the antibody can change. This is supermutation of the B cell that can happen. So the antibody become better at binding to the antigen and activating complement, and put the patient at higher risk of antibody-mediated rejection. So what the clinical significance of that? So C4d negative AMR exists. Plasma cells, I didn't tell you that, but the antibody producing cells are the plasma cells, not the B cells. And the B cell, when they differentiate to plasma cell, they lose their CD20 expression. And so the rituximab that we all use for antibody-mediated rejection is a monoclonal antibody against CD20. So it doesn't touch the plasma cell. So it affects the memory B cell, but not the plasma cells. This is why we're all moving toward using more a plasma cell therapy, like the bortezomib, to basically treat those positive plasma cells. Cytotoxic cross-match simulates a hyperacute rejection. Positive cytotoxic cross-match is an absolute contraindication for transplant. A positive flow cross-match and positive DSA are not. So 42-year-old African-American with history of end-stage kidney disease due to lupus, PD for 4 years, evaluated for a kidney transplant from her husband. CPRA class 1, 30%, class 2 is 10%. Cytotoxic cross-match is negative. Patient has anti-HLA-A1 against the donor with an MFI of 2000. Flow cross-match, though, T and B are negative. So which one of the following statement is correct? Patient is at high risk for antibody-mediated rejection, but at no high risk for cellular rejection. We said that this is not true. So there are T cells that precede the B cell activation, so they are at high risk for both. Patients at no risk for antibody-mediated rejection at the donor-specific antibody does not bind to antigen and does not activate complement. This is also not true, and then we said why. Patients at high risk for both antibody-mediated rejection and cellular rejection and should be induced with basiliximab. So it's high risk, that's true, but should be induced with, usually we use depletional induction therapy. In this case, we use thymoglobulin or Campath and not basiliximab, which I told you is an IL-2 receptor blocker, which is a weaker induction therapy. DSA is a contraindication for transplant, and patients should be activated on the deceased list. So this is obviously not true, and the correct answer is none of the above. Okay, so what is true regarding antibody-mediated rejection? Preformed DSA increases the risk of acute cellular rejection. Preformed DSA is an absolute contraindication for transplant. The histologic diagnosis of antibody-mediated rejection requires positive staining for C4d. Rituximab depletes plasma cells and decreases antibody production. So obviously, the correct answer here is A. Preformed, yes, A increases the risk of acute cellular rejection. We're repeating the same thing. And then the histologic diagnosis of antibody-mediated do not require positive C4D. So you can still have C4D negative antibody-mediated rejection. And rituximab does not deplete plasma cells. So now we get to the last part of the immune activation, and this is the resolution of the immune system. And this is very important because this is really explains why we reduce immunosuppressants over time. So when the T cell get activated with an antigen, they start expressing those, so they proliferate, but they start expressing those co-inhibitory molecules like the CTLA4. But there are plenty of those molecules, the PD-1, TIM3, you name it. So, but what does this do? This will let the cell, will inhibit the cells so it can live with the antigen. So remember here, in the case of the chronic infection like Hep C and Hep B, and the case of transplant, the antigen will still there. So the T cell is not able to remove this antigen. So it starts increasing those co-inhibitory molecules to live with the antigen and to save energy so it doesn't get activated all the time. And this is what allows us with time to reduce the immunosuppressant because the immune system is relatively inhibited. However, this is a reversible phenomenon. And once you reduce your immunosuppressant, you let your immune system to get activated more, all these co-inhibitory molecules will drop and a rejection can happen. And this is why we can have a late acute rejections when we reduce immunosuppressants. And then the last thing I want to go over is the regulatory cells. And why that? Because you're going to start hearing about the result of those trials that are ongoing currently. So those are the cells, as we said before, they exist in each clone of T cell that recognize an antigen. They express this FOXP3 molecule that it's a master regulator that make those cells more regulatory, which means when they encounter an antigen, they basically do not attack the antigen, but they attack the T cells attacking this antigen. So imagine now a scenario where you can take those, you take the peripheral blood of a recipient, you isolate those regulatory cells because we have surface markers we can use to isolate those cells by magnetic beads or by flow cytometry, and then we expand those cells ex vivo and we use them as cell therapy. But not only that, imagine when you isolate those regulatory cells, you're isolating them, they are polyclonal. You have from all those billion clones you have in the blood. So when you grow them against donor cells, you're only activating the regulatory cell and proliferating the regulatory cell that recognize the donor antigens. So you are developing cells that only are suppressive to the clone of T cells that are attacking the kidney, and they won't interfere with the rest of the immune system. So you're developing an antigen-specific therapies, and those trials are ongoing. There are a couple of those trials happening in Boston. So in summary, this summarizes most of what we talked about, and so I think we will have some. I think I have one more question to. Oh no. Okay. So I'll stop here, and thank you for your attention. I think we have a minute for a question, if there's any. Please.
What's the mechanism for negative drawing prednisone-induced rejection? What is the absolute minimum dose of prednisone?
So the question is, what the mechanism of the increased risk of acute rejection with late prednisone withdrawal? So, surprisingly, prednisone is the oldest immunosuppressant we know. Yeah, you know that prednisone is the least studied of all immunosuppressant, and the reason is because it was working and nobody wanted to invest time and effort in studying prednisone. The reason why, because prednisone probably work on on different mechanism than the other immunosuppressants. So when you unleash one of those mechanisms, you basically induce rejection. So, I don't have a very good explanation for that. And I'm sorry, what's your other question? So the minimum dose of prednisone we use, and Steve will go over this in a minute, is usually 5 milligram daily. Very rarely we go below 5 milligram, because we believe with this 5 milligram, the side effects are really, really minimal. Very good. So thank you. And